Hello, my name is Andrei. I'm a physiotherapy in Romania, and today I have the great pleasure of having a very good friend of mine here with me in Bucharest, Yannis Sotiralis. He's a very good friend and colleague, a physiotherapist, and together with him and other colleagues from both Greece and Romania, we started a small revolution, let's say. It's a revolution of manual therapy in Romania. It's the first time when we actually have an international accredited program that's running and it's functioning in Romania, and we can offer IFOMT recognized program, which in my opinion it's something excellent because it was never done, and I want you to tell us a little bit about you and why do you think it's important to have something like this running in a country where physiotherapy is growing and it starts having more and more opportunities.
Hi to you too. I'm very pleased to be with you in this setting. I'm a physical therapist, as you said, a colleague that I work about 20 years now. I came from also manual therapy, if you want, background. I was in my early years was engaged myself in Mackenzie approach, then Maitland approach, then Calderborn approach, and all of this. And afterwards, we met with a team that organized this program that has also full accreditation from IFOMT in Greece. And we try to integrate the modernization, as we discussed in other cases, of manual therapy or physical therapy. It should be a more proper term because I don't like really the differentiation. We are talking about musculoskeletal physiotherapy in general, and manual therapy or manipulative therapy. I think that this is a part of it. So yes, I think it's a very good procedure movement that we are doing now in Romania, trying to also incorporate this new knowledge to the Romanian body of physical therapists.
Okay. So you said that manual therapy or musculoskeletal physiotherapy, it's already included in the big term of physiotherapy. This year, also the World Confederation of Physiotherapy took the decision in shifting the name and call it World Physiotherapy. Mm-hmm. So why do you think suddenly everybody has this urge of unifying and keeping everything under one umbrella?
Well, I would say that this is the victory of science over branding. Branding, maybe it's a good thing for marketing purposes or for other reasons that I'm not in a way to discuss them because I'm not sure about them. But science is something that I know, and science is unifying things and don't separate them. We have to be able to judge things from a scientific point of view, and from this point of view we know that separations like manual therapy or physical therapy or other parts of our profession is not really a thing. Maybe there are things like expertise or to become more expert in some orientations of our professions, if you want. There are a lot of them, but you cannot say that there is a true separation between these lines. So this is my opinion.
I think the only separation is for the physiotherapists that choose to work, especially in pediatrics or in
cardiopulmonary rehabilitation
and or neurologic rehabilitation, yes. And they will proceed in these
different approaches.
Exactly, yes. In this part of their career. Yes. But otherwise, I totally agree. I don't think there is a true separation between things that should happen, because it's a different thing of yes. The things that should happen or happen in a very good environment for the patient, and things that unfortunately happen inside the system. So
yes, but you see that also at this point for the new physical therapist, it's a little hard to understand this kind of differences, because if you observe like social media or other resources, and I mean not the proper resources, that you will feel that you have to take sides. You feel that, for example, exercise is only the one thing that you can do and is allowed to do and it's evidence-based, or manual therapy or only passive modalities from the other point of view is the only thing that you can provide, or differentiation above differentiation. But in reality, there are patients that they are going to go well with passive movement at the beginning, and of course you want to incorporate very fast, to integrate very fast and active participation of the patient to the rehabilitation schema. But also you can have patients that they will go well with exercise only. There are different colors in the symptoms, in the pathology, but and also to the rehabilitation of the patients, I think. So I don't believe in these lines. Separation lines. I mean.
Yeah, I totally agree. And the thing that you said a little bit earlier about science that unifies the idea of physiotherapy, I think it's the best thing that could happen to our profession. And another thing that you said, it's about evidence-based practice and evidence-based treatments. Why do you think that we need this? Is it for us or is it for the patient?
I think it's for both. For the patient, good, and for our sake, it's better, because I think at least many years before, the physical therapist was having this kind of self-doubt of himself, because he was like a symptom reliever by chance, if you know what I mean. So yeah. We don't really knew why some of our patients are becoming better, and when we did the same approach to different kind of patients, we didn't have the real results. Now, with the modern clinical reasoning approach, we can differentiate patients with different needs, with different profiles, different phenotypes, if you want, biological or psychosocial phenotypes, and we can adjust our approach to different strategies and building different rehabilitation schemas. And this is also something that I think that it's working for the patient, but also works for us and for our psychology as scientists to become more secure for what we are doing and how we do it, with respect to the patient and to the guidelines that till now exist. And of course they change, but we have the obligation to always follow them.
So you just said that it's very important to follow guidelines, but in the same time to adjust each treatment to the patient's needs and to the patient in that moment, because maybe the patient will evolve during our treatment or during our interaction with him or she, and we can adjust always the treatment. So what about protocols? Do we need protocols?
I don't believe in protocols. This is only my opinion, but I think there is a lot of people that they share this kind of observation with me. We are needing, it's a different thing to follow guidelines. That's why clinical guidelines by definition are more wide. It's not like the results of a systematic review that can have, for example, a specific yes or no definition of their findings, and they can also justify them and characterize them like being strong evidence for this, moderate evidence for that, or minimum evidence for that. Clinical guidelines are there mostly to secure the patient's well-being, and then of course our behavior to the patient, and it's by definition more wide. We are willing and we have the tendency to treat patients the best way we can, but if you remember the Gauss curve, they are always far right and far left patients that they are not following what statistics say. So you have to be open to be able to see what is the specific patient's needs and the specific rehabilitation plan that you have in mind for this kind of patient, to give him a context to be able to follow.
On all this, as we already said, the treatment should be evidence-based and at the same time patient-orientated. But what about the patients that they don't care about the explanation. They only need or come to us and say, okay, make me good. I want to be healthy again.
Thank you for this question, because this is a very provocative one. Okay, and then you give me the opportunity to say, like, we have the problems with the branding, and we have to be either manual therapy or exercise therapist if you want, which is something that I will never agree, because as I told you before, there is a whole to this. There is a unity, not to this, not a whole. The same thing is with patients. The major thing that you have to be orientated is make your patient become better. So if at this moment it's not ready for you to understand, to explain everything of the thing that you are able to explain to him, and you can interfere with his problem and to modify his symptoms, then for me it's a good idea to do it. Have in mind, always in your back of your head, that at some point you will have to explain things to him, so this patient don't become like a patient that is hanging from his physical therapist. So you have to be able at some point to improve his self-efficacy and to improve his way of handling things with his life at some point.
So with this kind of patients, or with patients in general, we wait for the window of opportunities to be able to cut the umbilical cord, because
yes,
we don't want to create...
I could generally agree to this, even if I don't like also the expression window of opportunity, because it seems a little chaotic. But yes, I can feel what you're saying. We can start treatment if we have good responses of the treatment, and we can wait a little bit until, or we can work to build the relationship, to build the therapeutic relationship for the patient, to be able to understand what we have to offer to him besides intervention. Something like psychosocial, if you want, information that will help him with his problem in general.
So I think that's very nice of you, because from your statement, you don't want to wait for the window of opportunity. You want to build up the window. Yes,
and this is also explains why when you read something in at least when I read something in the social media, it seems to me very, very strange to see that there are people, for example, that say it's okay to work with pain. Don't respect so much the pain, because if you respect too much the pain, then you're going to build patients that they're going to have fear avoidance or fear of movement and things like that. From the other point of view, you have another guy that is saying to you that it's the best idea that you have to have is to control the exercise rehabilitation program away from the pain, because if you oversensitize the patient, you will make him become more sensitized, and then you will flirt with the situation of chronic pain, and this is not something that you could do. So I would say also that this seems to me like, again, branding and lines between patients and therapists. It's best for us if we see what the patients really needs at the moment, what we can offer at the moment, and if this thing that we offer him has results. And this is why we call it pain management, at least for the chronic pain patients and not for the acute phase, because we are talking about management. We are far away from the treatment.
For treatment. Although the road to chronicity, it can be very, very trickery, and can we do something for our patient not to get there, not to get chronic patients?
No, this is a very, very general question, and depends of the situation, of the symptoms, of the pathology. Generally, the best advice that we can have and try to work with is to minimize the time of the patient being exposed to pain behavior without being able to handle it, to move and to participate in everyday activities. This is our main goal. To specific situations, we can have some questionnaires or some tools that they can measure somehow the probability of a patient to become chronic pain patient and to maybe become more aggressive, if you want, in our measures, trying to avoid this. But generally, I would say that this is our main goal, to try to avoid very big exposure to the pain behavior, if possible.
Is there a difference between a long-lasting pain and a chronic pain?
For us or for the literature? This depends. I mean,
I think let's see if for us it's something different.
For
because
us, it should be different. It should be different for us because long-lasting pain definitely has, in his definition, in his setting, if you want, also elements of central sensitization, peripheral sensitization, and neurophysiological effects like this. But by definition, this does not imply that it has begun chronic. It is chronic from the point of view of time, but if we are talking about altered perception of pain in the brain level, this is not necessarily the case for long-lasting pain. I would say that indirectly you can say that if you are doing treatment and a patient becoming better and better, and maybe it's 100% better, then we are talking about long-lasting pain. So something went wrong, but we were able to fix it. While from what I know till now, and I'm saying this in a very modest way, I'm not familiar from something in the research and the literature to tell us that we are succeeding with real chronic pain patients. And we're talking about multidisciplinary teams and approaches, and still we are, I think, far away from successing.
But as you said, both of them have
successing. Sorry for the interruption. Successing treatment. We are succeeding in management and improving quality of life and improving functionality and other elements, other parameters.
But all these modifications that happen because the patient expresses a feeling, expresses some different types of things that he lives or she lives. All these are very subjective.
Yeah.
Would we ever tell to a patient that, look, this is not pain, you should see real pain, you should handle pain differently? Is it something that we can say to a patient, or we need to accept everything that the patient says to us?
If we are following International Association for the Study of Pain definition of pain and guidelines for managing the pain, pain is a subjective experience and cannot be measured, and it cannot be justified or criticized by an other observer. So the easy answer to this, it should be yes, you have to respect what the patient says. If he or she describes that he is in pain, we have to accept that this is
the reality
of this is his or her reality. And you have to find if there are modifiers, real ones, and not real is a bad expression, I mean biomechanical ones or psychosocial ones that can minimize or control the symptom. You cannot say to a patient that you are not feeling this amount of pain that you are feeling, because this is a dichotomy. So it's like making, so I'm not really know what I'm feeling. So it's a bad thing, I think, from a psychological point of view.
So this will, in my opinion, will make the patient not feeling in touch with himself. If somebody from the outside is telling him, no, you cannot feel this, it could not be real. How can you feel pain? It's something...
I would say that it should be maybe more useful to try to ask him and build a conversation. Okay, you have this amount of pain and I totally respect it, but are there any other things in your everyday life that you would like to do, and maybe to build a program of approaching these goals that you are going to set, and to have functional levels in everyday life for small targets that we can succeed together, to do things even without this pain, and to give him maybe distractions from his pain if possible, but always with respect of what he or she really feels at the moment.
Yep, I totally agree with this. And at one point you said something about I think the biggest thing that's actually happened about neurophysiology. Because all the things that we are doing, all the things that we say, all the things that we do with the patient or try to create with the patient will affect in a certain way the neurophysiology of the patient. Is this something important in physiotherapy, or should we care about neurophysiology and the science behind neurophysiology, or we should take it by granted?
No, this is a very difficult question to answer. I think neurophysiology is there, as biomechanics is there, as psychology is there, as all of the factors that made us as a whole personality is there. The social factors, our family, our work, all of this could play an indirect or direct role to someone's pain. So we take the knowledge that we are taking from the neurosciences and from the neurophysiology. We know what chronic pain states declares. We know what central sensitization is. We know now what peripheral sensitization is, and we try to approach these things. But I would not say that this is the holy grail of physiotherapy and you can base yourself only in that. And I don't think that this is something that anyone declares from the neuroscience point of view. We're talking about the biological, psychosocial model approach, but any of these three parts are equally important, I think. It's not a good idea to forget about biology completely. It's not a good idea to say and to minimize the effect of psychology or to minimize the social interference of factors that they could play a role to a person's pain behavior. So I would say have it in your side, incorporate in a clinical decision making, and see what the specific patients of yours is having as a dominant mechanism, if you like, also a general expression. This is something like functional movement restriction, pain, psychosocially, this patient is more pressed than before, is in a more anxious state. I don't know.
Because the complexity of the problems is very high, should we work alone with the patient or should we work in multidisciplinary teams?
I would say that generally it's a good idea to work with multidisciplinary teams because this is also, I think, that the new trend, that it's a good trend. I don't use the word trend as a negative one, but as a positive one. The interconnection of the science professionals. We know things from the psychologist point of view, but we're not psychologists. So we can use psychological interventions adapted to the physical therapist perspective, but still there are a big number of patients that they will need specialized psychologist approach or maybe a psychiatrist approach if needed. Some of them, they will need the person who works with the social services. So I would say, or some they will going to need an anesthesiologist to control a flare-up in their pain. So I would say, at least in the chronic pain patients or the severe pain patients, we definitely want to be in a multidisciplinary team. To a more everyday musculoskeletal problem, I would not think it as a necessity, but it's a good idea to have a circle, a scientific circle, to be able to guide your patient if needed to other specialties.
What about the opportunity of getting images from inside the body? Because this is an era where we have MRIs, we have CTs, we have a lot of dynamic X-ray and so on. Because also this enters in the multidisciplinary approach of the patient. Should we offer this option to the patient, or is it important for the patient to understand or to see what's inside the body, or is it important for us to see this?
I would say that this depends of what kind of pathology we are dealing with, and this is not necessarily a question for us physical therapists. This is a question also for medical doctors to make decisions that is considered to be efficient, safe for the patient, but also efficient for the health policy systems and the economy behind the health systems. Because we have data from research that they say that there are a lot of times that when we try to explain to a patient what is really happening and we use the wrong expressions, we maybe put fear on him and to make the situation even worse. So you see that I don't want to go very wide to this, but you see that there is a balance. There are situations like a red flag screening that maybe it's appropriate for the doctor to prescribe some imaging work or other interventions to try to understand if there is a possibility of a red flag. But in a big percentage of musculoskeletal conditions, if they don't fit the criteria for being in a more wide state of imaging techniques, it's not needed, I would say. We follow what guidelines says to this, and mostly the doctors follow guidelines to this. If this patient seems to need a more extended, more thorough look up to his problem.
During the last years, there is a discussion about overdiagnostic, and most of it is done by too many things, too many analyses that we are doing, not we personally, but the medical healthcare in general. It's medical system in general is doing for the patient or to the patient. What do you think about overdiagnosing a patient or putting a diagnostic to the patient?
This is also unfortunately pathology dependent. Definitely this is something that we have seen in the literature, been there. And to be fair, I would like to say that yes, over medicalization is there in a lot of fields of medicine, but also we as physical therapists, we try to over physical therapyization, if there is such a word. We see instabilities that they are not exist. We see asymmetries that don't play a role. We see postures that we think that they play a role. So we are over medicalizing our profession sometimes, which is completely wrong.
You just said about posture. Does posture play a role in the whole story? Is it such an important matter that we need to approach?
Again, this is a plane of our first line of our discussion. This is a game of lines and boundaries. I don't believe in this kind of boundaries. So when I read something on Facebook, I read a part of healthcare practitioners, I will say it in general, that they will say posture doesn't matter at all. To a point, I totally agree with them. And there are others that they will say, but posture really matters. Biomechanics says this, this, and this. If you put these two declarations in everyday practice, you will see in reality that practically posture doesn't really matter until some patients could play a role. So generally the best posture from what we know is don't have a favorite posture. So change continuously, because we are not built to sit on a chair. Even we are sitting in a old school biomechanic in a correct procedure, or we are sitting in a slouch position.
Yeah, but so the posture, it's about time.
Yes, posture is about time. Posture is about psychology sometimes. Posture could be a lot of things. So generally, I would say that we are not saying that there is a linear relationship between posture and pain. Definitely there is not one, and we know from the recent the literature research that the structural model that told us at the beginning that posture plays a very significant role is not the reality. But from the other point of view, it's also a nihilism to say that posture never matters. Because if this was the case, why if I correct someone, then suddenly he's not having pain now? And I'm not saying that this is the solution for his problem, but it's a pain modifier, so why I cannot use it? For now.
Exactly.
I will not put him on fear and I will teach him, be like this for every day of your life. But this moment could be a pain modifier, so I will use it.
So posture, it's important when it's needed,
yes,
or
exactly.
When we need to talk about
for
posture.
A specific time.
Because at the end of the day, posture only means the position of the body at a certain moment in time. So it should not be the boogeyman from the closet. So physiotherapy, as I understand and as we talk more and more, it goes in a certain direction towards education of the patient, education of the family of the patient, and education of the other professionals how to interact with the patient. How do you manage this kind of provocations? Yeah.
Yes, education is something that we are trying to integrate to our profession, and as you said, it refers to the patient, but it refers to ourselves as well. For being able to educate someone, you have to be able to educate yourself first, and I would say to educate you in a proper way, to be able to know your limitations, to be able to know what you can really offer or not, and based on scientific data to share the knowledge with the other professions, and to be able to build a team that you will share the same approaches to the given pathologies. But it's not only theoretical. So education is not only talking to the patient. You have to be able to be to his everyday life and to give meaning and context to what you are going to explain and educate him with something. It's not just theory, because in any other situation we could give him a book to educate himself. So it's not this simple.
Just read this,
Yes,
everything will
everything
be
is going to be okay.
everything is going. At one point, Jill Cook said that we need to start to teach what is necessary, not what we like.
Yes, exactly.
So, what do you think about this? Is it because every one of us at one point we have some interesting feelings about an idea, about a certain type of therapy, but
I would say that I agree very much with the Professor Jill Cook to this, and I will, if I would like to explain it a little bit, I would say that this, you see that we are making circles now, because we are talking about situations that practically are interconnected. So, yes, but we can have different patients. Some of them, as you said before, they want us to just help them deal with their problem, and they don't really give and they don't pay attention to what we really have to offer them in the point of explanation, why they are in pain, why their pain is flaring up in this and in these situations. And they really want from you at this point to make a program, a rehabilitation schedule to help them move out, and then they will forget about you. And this is a good thing if you succeed to do this. You have patients with different needs that they want for real to understand what possibly could go wrong and have this pain and restriction or something that it troubles them. So then you are in a position that you have to explain them what you think that they are having, but this is the point that you have to respect what science-based medicine, science-based physical therapy is saying to you. It's not a good idea to talk about facet when you are not knowing facet, for example, in the spine is the main origin of their pain. It's a good idea to express it differently, to a non-fearful way, to say maybe there is small pain and restriction to this movement because of non-optimal loading situations, and I will help you to build this. So explain yourself, explain the possible mechanisms of the pathology to the patient, but in a less provocative and fearful way that will add probably to building a fear avoidance behavior to the patient. Don't put too many fear on them for situations that we really know that if we can handle them correctly, it will resolve.
And they can actually live a normal life,
yes.
And they can live their lives.
Yes, of course.
This is something that we actually, I think that we need to take full responsibility, because all the words that we are saying to our patients will make a modification in their behavior. And if we give them too many things to handle and to understand, at one point they will totally shut down. And,
yes, of course. And it's more convenient to us, depending our backgrounds and what we learn when we are in school, to categorize patients in specific categories that we learned back then. And practically, this is not the proper way to categorize patients at the moment. So this is how neurophysiology comes in, and how you can express yourself in a more accurate way, excuse me, than to say that this is a specific tissue problem from this specific tissue. Well, in reality, you know that you cannot be so specific.
And also, if you can be
know your limitations.
Exactly. If you can be so specific, that tissue will change because we have bioplasticity and
Yes,
we have
probably,
neuroplasticity, and that tissue will adapt, and that tissue will adapt to load, to unload, to whatever we put it through. So at the end of the day, I think our job should be to be an educator, a partner, guidance to our patients, and to help them with our best knowledge to get better.
Yes, and to succeed what their goals are to this given situation.
Okay. Thank you very much, Yannis.
You're welcome. It was a very good talk.
Yeah, for my opinion, yes. So thank you very much for being a part of this project. Thank you very much for putting so much passion into this, and from taking your time in offering other colleagues of ours a part of your knowledge, a part of your research, and a part of the things that you believe in.
Thank you very much, and I would like only to add that I also enjoy teaching to this, because I think that I continuously learn new things when I teach people, because somebody will ask me a new question and it will show to me a new angle that I wouldn't probably think before, and this is also something like a self-improvement for me. So thank you very much also.